Uh, Thank you very much for the lovely words. Uh, I will start my oration by Charan Vandana of respected Madam Mehra, uh, respected Dr. G.D. Puri, my very dear Dr. Naresh Panda, who gave me this opportunity, Dr. Rajiv Yande sir, to have opened and talked so beautifully about Dr. Mehra, and the faculty of PGI Chandigarh for organizing this beautiful event. Professor Wine Mehra Oration is, believe me, uh, better than any other honor I have got till today, and I'm grateful to Naresh once again. When I had just joined PGI in the March of 1980, Professor Mehra was leaving the department, and that was the saddest part of my life, actually. I was happy to have joined PGI Chandigarh, but I was very sad that he was leaving. And all my years, I wanted to be close to him and just be able to see him from a hand's distance. And when I became the organizing chairperson of the third SIGI, which I had held in Vigyan Bhavan, and I had invited the Honorable President of India, the great Abdul Kalam Sahab, all the program was written by the committee which we had, but I just stood for one thing, that in this I had to honor one person, which was Professor Mehra. Can you believe it? I had never even worked with him, but I wanted him to honor, and everybody agreed. And this is the picture there. You can see our great Abdul Kalam Sahab, me, and Professor Mehra. This was probably maybe something of the last janam which I had to give it back to him, because I never was his student, but I had always heard great things about him. And I think this was the best thing I got after becoming the organizing chairperson of third SIGI. But my stint in PGI Chandigarh started in 1980, lasted till 1983. And as told by Dr. Rajiv Yande, we had another great stalwart, Dr. MML Arora. Though I was always afraid of him because he was a perfectionist, and but I learned a lot from him. The best thing I learned from him was how to face the Western people, because I had in my later life the opportunity of visiting almost every country in the world. And I was there as a WHO fellow for 3 months each at many centers, which I'll just tell you. And there I remembered one thing which Dr. Arora had told me: oh, don't get impressed by these people. We have more experience and more knowledge than these people have. So don't just get carried away. Try to do what you wanted to do. And that was a big thing he had told. And I always remembered that. The next teacher which I had was Dr. Pandhi, my soulmate, I would say. He was the one who taught me everything about ENT, the small things which I learned from him. And I always remember the gesture he had showed when he called me for his first laryngectomy outside PGI. He had left PGI, and he was doing his first laryngectomy, and he called me. I was in exam going then. And we did that laryngectomy on a trolley, because in his nursing home that time, the table did not arrive, the operating table. And he told me, Dr. Hans, will you assist me on the trolley? I said, sir, even if you tell me to do it on the floor, it is an honor to be with you. And you called me to assist you. It's such an honor. I touch his feet, virtually sitting from here, my great Dr. Satish Pandhi, sir. Dr. Maan was more of a friend. And without him, the stress of PGI would not been, it was impossible to take that stress which PGI Chandigarh gave. Because I remember, I was told that even a gadha becomes a horse there. And we were all asses when we came there, and we came out as the stallions. We came out as good horses. all credit goes to our teachers from PGI Chandigarh. We lost Dr. Maan, but he's always in our heart as a great friend and a great teacher. We made great friends. Suresh was 6 months my senior. Achal was 6 months my junior. And Kabir was 1 year my junior. And they were great friends. I think their humor kept me in PGI despite the hard work we had to do. My journey after PGI was quite different than being in PGI. My first posting was in RML as a senior resident, though I wanted to remain in PGI, but somehow I could not. And my first posting was in Ram Manohar Lohia Hospital for 3 years. And after that, when I became a specialist through UPSC, I stayed in RML as a junior consultant. And I used to go to Parliament Annexi and set up a ENT department there. And I used to go there for 2 hours pre-lunch. And the rest of the time I was in RML hospital. So that's how my journey started. But PGI made me a cancer surgeon. I remember when Dr. Arora sent me and Dr. Suresh Sharma to JJ Hospital, Mumbai for 3 weeks to learn cancer surgery. When we came back, we once were talking to him and he said, "Oh, everything is operable in cancer. You can't say, don't operate this, we can't operate this." So carotid ligations, bilateral block dissections, total laryngopharyngectomies, pullover surgeries, esophagus, there was no end to it. Bilateral maxillectomies, there was no end to it. But gradually, after coming back from PGI, I did that for a few years, but then actually got bored of doing cancer surgery. And that was the time when I was thinking what to do next. And just because I was a good laryngeal surgeon, I landed up doing laryngotracheal surgery for some time. That was about 7-8 years. After which, because I had worked with Dr. VP Sood for a lot of time in Delhi, I switched on to rhinoplasty surgery. And from there, because I traveled around the world in my WHO fellowship to many cochlear implant centers around the world, I became a cochlear implant surgeon. And today I call myself an inner ear specialist because now it is Dr. Hunt Center for ENT, Hearing Care and Vertigo. So I primarily I'm doing only ear and only inner ear for that matter. I have 4 juniors who do rest of the surgeries, even cancer surgery, but I specialize in that. Now I would like to tell you a few things which I did in laryngotracheal surgery. And as Professor Jayamanti said, that I also developed the Hunt speech valve. It was during these days, and I would pick up cases in RML which were, others would say no, and I would say that was the PGI training. So this was a case in which there was a long laryngotracheal stenosis post-intubational, and I said I'll take it up and start doing. And this is, you can see this is the intubational tube, and this, after the resection would have been done, this would have been slided down, and we started removing, and you can see almost 4.5 centimeters of trachea we removed. 2.5 centimeters we got from the laryngeal drop, and the rest 2.5 centimeters by flexing the neck and stitching the chin skin to the sternum skin and keeping it there for the next 2 weeks so that we didn't have to put a tracheostomy tube or a T-tube. And this was the 4.5 centimeters we removed, and then did an end-to-end anastomosis, extraluminal and extramucosal by pre-placed sutures. And you can see the post-op video showed absolutely normal airway of this person. And 2 years later, you can see, except for the bad keloid, which formed along the Sorensens, which we had taken, a very large Sorensen, because, bringing out that kind of a large piece and doing an end-to-end was a little difficult. But this was on the table, no T-tube, no tracheostomy tube, and the patient became all right and absolutely fine. The other case which I remember of the laryngotracheal trauma, which I used to do, was a large defect of the skin and the anterior tracheal wall and a stenotic area of the glottis. And this patient, you can see, came to us with this. There was an injury, multiple surgeries done. And when you see a close look, you can see that there was epithelialization of the posterior wall of the trachea, and there was tracheal stenosis. There was bilateral cord palsy and a bad situation of the trachea. And I took up this case. I don't know what I was thinking of doing, but I had just brought a tracheal mesh from Canada when I was in Toronto. Some tracheal surgeon was using a tracheal mesh, and I said, I'm going to use this. So I said, okay, I'll try this case. And first we did a laryngo fissure, did a one side unilateral cordectomy, and then closed it on the T-tube. You can see that this is being closed. And this was the tracheal mesh. It is a monofilament polyethylene mesh which we used to close the tracheal defect, so that there is no paradoxical respiration which occurs if there is no stiffness in this area. And you can see this has been closed. And then this was the mesh which we used. And this gap of the skin was covered by the deltopectoral flap. It was covered by the deltopectoral flap. Sorry. And the third day, the patient was speaking. This was almost like 7 years after that the child spoke, and he started crying. You can see the tears in his eye. He started crying because he was never able to speak. There was glottic stenosis and there was loss of this. He could not cover it and speak. And the third day he spoke and told his name. He started crying. On the third week, we removed that. And on the third month, we removed the T-tube also and put the thing back, and he was absolutely normal. The beauty of the tracheal mesh was that the tissue grows inside through the pores inside on the other side and lines the inner side of the trachea also. And you can see this is the Hunt speech valve which we had developed during that period when I was doing these tracheal surgeries. And because the Springer valve, speech valve was very costly, 6,500. This was a silver thing which I made for just 150 rupees. So this was very effective, and I used to use this, though my first lecture I had given in PGI only, and showed this thing, but it never got used because I stopped doing tracheal surgery after that and went on to rhinoplasty surgery. So there was nothing new, nothing which I have to tell about rhinoplasty because all of us are doing, and there was nothing so great I did. But it was cochlear implant surgery, which I started doing in 1999. Again, going against the tide, I started the Varia technique. This was probably in my nature to do something different because every time I would get bored of the surgeries, routine surgeries, and every time I wanted to do something different. And so I picked up. And this also, from 1993 to 1998, I visited all these places, the House Ear Institute, Children's Hospital, Toronto, Canada, Ear Clinic, Würzburg, Germany, Ear Hospital, Tokyo, Japan, and the Bionic Ear Institute, Melbourne, Australia, for 3 months each as a WHO fellow, and learned about cochlear implant in a big way. Not only surgery, but what cochlear implant was, what happens when we put inside, all those changing trends which were happening during those time. In those 6 years, 5 years, I learned. And when I started doing it 1998, I met, he was my inspiration. Everybody knows the great man, Professor Graham Clark from the Bionic Ear Institute, who invented the cochlear implant. And it was such an inspiration being with him for 3 months in Melbourne and learning the tricks and trades of cochlear implant surgery. And with all these, Professor Brandt, Professor Pyman, Dr. Nedzilski in the House Ear Institute, again, Dr. Graham Clark, and they were great inspiration to me for cochlear implant. And when I came back in 1998, finally, I said, no, I have to do cochlear implant. But then I met this gentleman. In 1998, I met this gentleman. I had gone to Saloniki in Greece, and I met Dr. Trifon Kiradzitsi. He's my soul, my teacher, my everything. And he told me, Dr. Hans, I think cochlear implant can be done by a different technique. And I said, sir, I'd like to see you. And he had these 2 surgeries and showed me the Varia. Can you believe I said, sir, this is the surgery for cochlear implant? Just seeing those 2. And I requested him, sir, will you come if I keep my first case? Because I've traveled around the world, learned about the posterior tympanotomy, and I want to do your technique because I think this is a better technique. So he told me, yes, I will. Dr. Kirtane is also calling me for a few surgeries, and you come there and see those also, and the next day I'll come and help you. And can you believe that 5 surgeries he had at the uh, in Bombay, where Dr. Kirtane was. And I kept saying during the surgery that this is a very easy surgery and very easy surgery. I'd seen Dr. Trifon doing it in Saloniki. The next case, he asked me, Dr. Hans, you scrub and do the thing. It was Dr. Kirtane's case, and he asked me to scrub. And can you believe I assisted him? And the next day, 14th August 1999, was my surgery. When he came, I said, sir, will you not scrub? He says, no, I've seen you. Now you do it, and I'm sitting outside. And can you believe my first surgery? He said, you do it. And he just sat outside. That was the kind of confidence he had in me, and the blessings he gave me was immense. And this is what Varia was. Instead of the large mastodectomy and through the small little hole of a posterior tympanotomy, now you create a tunnel which is 1.4 millimeter and growth permeatally. You see a beautiful panoramic view of the middle ear cleft, the promontory, and you can see that this is the tunnel, 1.4 millimeter, vis-a-vis the large mastoid cavity which we create. That is the lateral semicircular and the facial far behind. And this is how I did. And you can see that this is the Varia technique, and this is the posterior tympanotomy. And I just didn't look back. I just kept doing the Varia technique, which was very easy. It just takes about 35 minutes for me to now complete the implant. And I feel this is one of the best inventions Dr. Trifon Kiradzitsi make. And this is how it goes about. The only thing is, many of the seniors still think that it is a blind surgery. But if you have the embryology in your mind, you will not find it a blind surgery. And it is a very, very simple. You will not be able to injure the facial nerve. I have done over 3,000 cases now in the last 21 years, and never have there any be a problem. I'll let you know how it is all about. And you have a beautiful view of the cochlea. You can do a round window insertion or a cochleostomy. You can shape the cochleostomy in such a way that the electrode just goes inside beautifully. And you will see that these are my initial cases. You make the tunnel in line with the cochleostomy so that you don't have to do anything. See, the chorda is still intact and the electrode is going inside the cochleostomy straight. So that is the beauty of this technique, and without any complication. You just have to direct the electrode inside, and it goes all, even the medal, which is 31.3 millimeters, it just goes in smoothly. So, and the drum is put back. It is even less than a stepidotomy, I can tell you, that easy. So instead of going through that posterior tympanotomy, you have a beautiful view of the middle ear through which you do the major work of doing a cochleostomy and putting the implant electrode inside the cochlea. And the magic behind this is the perforator. You have to use it with both your hands, because on the right side, which we do 80% of the cases, you'll have to do it with the left hand. And on the left side, which you do about 20%, only when you're doing, when the right is contraindicated or you're doing a bilateral, that you have to do it with your right hand. So you actually have to be using both your hands if you are doing a Varia technique. And the beautiful perforator, as we call it, it is called the Trifon perforator. And this is the magic of the Varia technique, but you'll have to really master it before you start doing. And in 2002, when I had just done about 50 cases, I was called for the first Varia or the Transcanal conference in Dead Sea, Israel. I was the only Asian then. And now there are over 75 surgeons only in India who are doing this technique. This is Dr. Trifon and the team of people who were learning this technique gradually. And most difficult situations were made easy because we had a panoramic view of the middle ear. You can see an anteriorly placed sigmoid sinus still would be almost touching the posterior canal wall. We could still create that tunnel. An ossified cochlea in the basal turn and a distant cochleostomy with a high jugular bulb, we could do it easily. A decent facial, and still we are far ahead of that. A decent jugular bulb, and still we could do a cochleostomy where we wanted. An ossified cochlea to this extent, and we had to drill out 7 to 8 millimeters of the cochlea before we entered the scala tympani. Now just imagine another half a millimeter, and you have the carotid canal there. And people have put the electrode in the canal, but here we could drill that much of the cochlea. We could see the promontory, keep drilling till we reach the scala tympani and put the electrode inside. And gushers, you can just see we invented the three-hand technique. Can you believe we have still the gusher on and the electrode is already inside? So this is the beauty, because you have a panoramic view. You can use three hands. Your junior will hold the suction, and you can with two hands pack the cochleostomy so well that it stops gushing on the table, and there is no problem post-operatively. So this is the three-hand technique of dealing with a CSF gusher, which I had to encounter a lot because I was doing single cavity cochleas, basal turn fistulas, connectivity with the intra-aortic canal, large cochlear aqueducts. All these would give you a bad gusher, and you should be able to have a beautiful view so that you can take care of the CSF gusher post-operatively. Now, over 3,000 implants, and I had never a facial palsy. Please understand, there were 3 paresis, 2 completely recovered and 1 incomplete recovery. And these were because during the surgery, when I was explaining and making the tunnel with the perforator, my junior, and I was concentrating on answering what the questions were coming, and my junior did not put the saline, and that heat actually destroyed the nerve. And in one case, pretty badly. In 2, recovered after 3 to 4, 6. But there was never ever any flap necrosis, implant extrusions, no implant failures. Because if you are putting the electrode nicely inside the cochlea, neither are you injuring the cochlear internal structures nor the electrode. So, and less than complete insertion was just in 12 cases out of 3,000. And these were the cases where either there was a single cavity in which the electrode would not go, or there were ossified cochleas in which the whole electrode will not go. And there was no case of misplaced electrode. I saw in cases where the posterior tympanotomy was used. Now just imagine this is the electrode in the carotid canal, that is in the eustachian tube, that is in the hypotympanum, and this, I don't know from where it came into the CP angle, and in the brainstem region, the electrode came. The other is inside the cochlea, but this came. So I was called for doing a revision, and we removed it. There was a massive gusher, but we could do it and pull it back. But how did it go there? I don't know. But this is the kind of situations. But see, all these surgeons were great surgeons, and they're still stalwarts. But just because they had to work in the angle of the chorda tympani with the facial nerve, that the area was so small that they could not see at times that what they were doing while putting the electrode, that they went into wrong situations. So it is not these days. Please understand, all surgeries will have some kind of problems, but you will have to deal with them as quickly as possible. A hematoma, don't wait, immediately aspirate it. Immediately. Next day you should aspirate. Because if you don't, if you try to give pressure bandage or do something, you will, the blood will become hard, and then you'll have to give an incision and drain the clot from inside. It will not go. That much of the blood collection will not go just by pressure bandage. Don't try to delay. Do it as early. If there is a bad skin, which will happen in any case, if the stitches have not been given properly, you can have a bad skin, a keloid. You remove it as early as possible. Don't try to postpone it. And you can see that we are not touching that area of the post-oral region. We just gave that incision, removed that bad skin, stitched it back, and absolutely normal. There are complications. Every surgery will have a complication. But if you do a septal perforation in a stepidotomy, that is wrong. Now, if you delay it and this organized blood gets infected, then you are not able to save these implants. So please don't wait. Do it as early as possible if you don't get into these kind of situations. I never got into, because I would immediately request the patient to come and get it operated and get it treated, whatever problems have occurred. Yes, if you try to push it through a small incision, you will put the coil in such a way that the tissue starts to grow under it and it will come out. So you will have to correct that also as early as possible. This is a delay case, but you should identify it early. You understand that the receiver stimulator is not absolutely subperiosteal on the bone. The tissue has started growing under it. Immediately do it before it gets into this kind of a situation, and you will be able to save the implant. Yes, again, if you are pushing the electrode receiver coil through a small incision, the receiver coil would get angled, and a little incision, little trauma to the edge would lead to the magnet coming out. Or if it is an MRI incompatibility, these things would come out, and you should know how to put it back. All these are for budding surgeons. I think the seniors all know it very well, but please try to do it as early as possible. Don't wait, because the moment you wait, some reactions would occur, infections would occur, and gradually you will have to lose the implant. So don't do that. And once I was established, I'm grateful to all the centers who started calling me around the country and in SAARC countries around the world, where I went and did all these surgeries. And I'm grateful to all my students who learned from me, and I helped them learn this technique so successfully that they are now all doing these technique. I did children from almost every part of the world, whether it was US, Nigeria, Iraq, Iran, Kazakhstan, everywhere. So almost everywhere, from every part of the world, I operated, and even did 8 to 10 implants in a day. Please understand, that's a big, and not once, many such government programs which I was covering, where I had to do 20 implants in 2 days. I would start early in the morning, about 7 o'clock, and by 6 o'clock, do 8 to 10 implants in a day. Yes, there were about 2 OTs running. I would do one and somebody would close. I go to the other and then come back before they had opened up. So just imagine, this surgery was so quick that I could do so many implants in a day, and so many at different centers. And these people learned it better because they were seeing so many surgeries being done on the same day. Because if you see one and then see another after 3 months, you tend to forget. But these people became so good in their work, and they learned because I could do so many implants in a day, and all successfully. Believe you me, please understand, during these 8 to 10 surgeries also, never ever there was a facial which I gave in. So hurrying up did not spoil the thing, just because the technique is so beautiful that I could do so many with no problems at all. And then once the technique was established, people started calling me all over. Thanks to Naresh for having called me for this great Professor Mehra lecture today. I think this could be anybody's delight. From where you have studied, you are giving the oration. Thanks again to Naresh for giving me this opportunity at orations, at AOI, at neurotology, at every place I gave lectures. Not only that, Pakistan, Bangladesh, Afghanistan, all these countries and SAARC countries, I went and operated and gave lectures, and around the world, at the Asia Pacific, the European Symposium, all these places I had the opportunity, and people were gradually taking Varia also as a surgery. I still say that there are people who have their own this thing, they want to go, but I don't say both the techniques are good. But believe you me, if you try doing this, you will find it very, very easy technique, very easy technique. And there are now 75 surgeons all over India who do this technique very beautifully. The feather of the cap was when the Cochlear company called me in 2018, and they wanted to see whether I'm scientifically and histologically right doing this technique. And in 2018, just imagine, almost 18 years after I did my first implant, they made me do 2 temporal bones and then did a histopathology. And in both the cases, they saw that neither was the chorda injured, nor was the lateral semicircular canal injured, and the facial was far behind. Both histologies showed that there was no problem and the facial was far ahead. And I've always been telling that if you know the embryology, you will never go wrong, never ever go wrong, because the facial recess means the facial nerve can never be in the facial recess. So we have to learn that this is not a blind technique. The only technique when we are doing trachea, we have to be not seeing the recurrent laryngeal nerve. We have to be as close to the tracheal rings as possible, not try to see, and we will save the recurrent laryngeal nerve. So sometimes you have to go the other way and see that we can do. And now so many cases, yes, my juniors have given facial. Either they have not done temporal bone dissection properly or they have become overconfident. Please understand, never overconfidence, which when I do my case, I do it as the first case every time, even today. So that you have to respect the child, respect the surgery, respect what their parents are giving you, their children. So you have to do it meticulously. And lastly, I would just mention the angel in my life. I must tell you that he read an article about minimal invasive technique on surgery and called me to Rashtrapati Bhavan and wanted to know what I was doing. And I was given only 15 minutes that day. This was sometimes in 2004 by August or even a little July. And then he put me in the DRDO program. And then I was surprised that 2005, next year, he gave me the Padma Shri. Because please understand, this was the DRDO program he had put me, and I did the animal trials there. This is the DRDO office in Vizag, where I was invited, and it was an honor to be with him. But in 2005, the greatness of this man was that he was told that no government servant can get a Padma Shri. You know, that's the reason why no IS officer gets and no person in the government can actually get a Padma Shri. But he said, no, I have to give it to Dr. Hans, and that's how, being a government servant, because AIIMS and PGI are autonomous bodies, they're not under government. They can get it, but nobody. I was the first and the last ever government servant, working government servant, because of this great man, because he said, no, I have to give, I've seen this man, and that's how I got it. And I'm honored that I got it from this great man, and it is just such a pleasure to be. There were other people who honored and felicitated me by different thing during my course, but this was the Chhattisgarh Ratan I got from the Chief Minister, because I had done about 200 plus implants as government program there. The International Rotary Award, vocational award, which was given to me, I was called to Dubai and given this award, and a lot of money to do these implants. Almost 2 crore rupees I was sanctioned, and with that I could do many implants in poor people, and that was the award they gave me there. And then the chief guest and professor emeritus, which I got from Vaidehi Institute of Medical Sciences, Bangalore. I'm the professor emeritus still there, and I go and operate, and they call me. Thank you very much, Vaidehi Institute. But the blessings came from the Pingalwada Trust. Madam once called me, Madam Inderjeet called me and told me, Dr. Hans, you have to start the program in Pingalwada. So I was saying, she must be joking. In the deaf and dumb school on the 3rd floor, she says, we'll make an OT here and you have to come. And unfortunately for me, the first case was a Mondini deformity, and I had a gusher, but all went right. And every 3 months, 4 months, they would call me for 3-4 surgeries. We have done about 20, 25 there. And then she honored me, and this was a blessing from that great lady from Pingalwada, and I'm still remember. So this is the best blessing which a child who has started hearing and speaking can give you. And I think it is a blessing that all of us who are doing cochlear implants, including Dr. Naresh Panda, he does it so beautifully. We give 2 things. Please understand, we not only give hearing, we give speech. So it is a blessing that we are cochlear implant surgeons today and give such kind of children. In Innsbruck, every year now we have a workshop in our name, in Dr. Trifon and my name. And just because there are 8 temporal bone stations there, we call 4 from India and 4 from out of the world, around the world, where we refine their steps in Varia technique. And this happens every year. This time it did not happen because of COVID. So next year again, inshallah, it will happen. And now we have the Dr. Hunt Center, where we have 2 temporal bone stations. And anybody who comes here can do the temporal on fake-on bones, please, because we don't get the temporal bones now in Delhi. And we have an auditorium with 50 seats where we can, an AVT, switch on, audiology, state of art, 5,500 square feet of only OPD. I don't operate here, but this is what we have. And now I call myself an inner ear, not only hearing, but I also take care of the vertigo. We have a state of art habilitation and diagnostic center, VNG and all these things. And one thing which I would like to tell here, and sometimes maybe later tell you about, is steroids, which are helping not only patients with Meniere's, but with sudden sensorineural hearing loss, acute tinnitus. And every day we have I have 4 stations in my clinic where as many as sometimes 8 to 10 injections we are giving, and people are coming just because they're getting better. So now my center is not known as Dr. Hunt Center for ENT and cochlear implant. It is called Dr. Hunt Center for Hearing Care and Vertigo. So, but please understand, all these years I did not leave one thing or change one thing, and that was my golf. Started in 1985. I have won a lot of tournaments, and still at this age I play golf with all the passion, and that is the relaxation for a surgeon who has to undergo a lot of stress in doing all these things. Thank you very much. And once again, thank respected Madam Mehra, Dr. Puri sir, Dr. Rajiv Yande, Dr. Naresh, for having given me this opportunity. Thank you, Naresh, very well. And all the staff in PGI Chandigarh for having given me this honor. Believe you me, I'm very nostalgic, and I'm very grateful to all of you to having listened to me like that. Thank you very much.